Hi, everyone. My name is Brianna, and this is my presentation on the case of Melinda managing ASD using CBT interventions. So, this is just an agenda to start with. So, first, we'll look at the overview of Melinda's case, and then we'll look at the assessment, the conceptualization, treatment goals and interventions, and finally, the strengths and challenges. Over here to the right, I just have this little picture that says autism is not a disability, it is a different ability. Here, I like to start off all of my presentations with a quote. This one is by Ralph Waldo Emerson. It says, "To be yourself in a world that is constantly trying to make you something else is the greatest accomplishment." And over here, we have like a little GIF that's like saying, "I have autism and I matter." I really like this quote because to me, it's saying don't conform. You It's basically saying you are unapologetically yourself, regardless of society ways of trying to get you to conform. And fun fact, Ralph Emerson was actually an American essayist, philosopher, abolitionist, and much more, who strongly believed in self-reliance and non-conformity, which I felt fits the theme of this very well because there is no need to conform exactly. There are skills that can be acquired to assist with the symptoms that come along with the diagnosis. So, a quick overview of Melinda's case. The client is a 17-year-old female that is from a lower middle class suburban neighborhood with both her parents still being together and in her life, in a sense, because they are rarely involved due to their work schedules at the truck stop that they both work at. She attends a mostly Caucasian high school, and she was referred to therapy due to concerns by her teacher pertaining to her lack of growth in several areas, including socially, intellectually, physically, and emotionally. The teacher also mentioned that Melinda walks around in a daze with her eyes covered by her hair or pulled back with a rubber band, possibly indicating some self esteem or self image issues. She doesn't seem to have any positive social interactions or relationship with her peers, often going ignored by those around her, including in her special resources class, which has gotten her used to a routine of just getting through the day without communicating with anyone except for her teacher occasionally. The parents haven't been too involved in her life, including both at school and at home, with her often being alone after school. The counselor also mentioned smelling alcohol on the mother's breath when she came to pick up Melinda one day, and how she expressed their disinterest in being involved due to their work schedule. However, she did complain about Melinda's behavior and how Melinda doesn't do her work, housework, and or chores, is often sullen and sulky, and she just doesn't make any friends, according to her mom. Melinda, Melinda typically follows a daily routine that rarely changes due to the lack of outside social stimulation with anyone, including her parents. So she doesn't really get social interactions or any type of social stimulation. She's normally just a set routine: get up, go to school, get through the day, sometimes communicate with the teacher, get back on the bus, get home, fix herself, feed the dog, fix herself a frozen TV dinner, and then watching television until it's time to go to bed. And then she repeats this routine. So, in the assessment process, the initial mental status evaluation showed her having sullen and sulky behaviors as reported by the teacher previously. She was very avoidant of eye contact, with other behaviors such as like gnawing on her bottom lip and picking at the lint found on her clothing. She would pick it all piece by piece. During intake, the client actually showed signs of being in a bit of a daze, as mentioned, and had a very still, indifferent sort of aura around her. She also had a slight slouch in her walk in the way that she sits, and she was sure to like have her hair. It was pulled back mainly, but there were some strands out that was enough to cover her eyes and part of her face as well. She also appeared to be very small in stature and avoided touching things. She was very cautious about the things that she touched upon coming into the upon meeting. It was very interesting because it seemed almost as if she was afraid to be reprimanded for maybe touching things that may not be like just simple things, desk, lamp, things like that. Symptoms that the client presented: persistent deficits in social communication and social interaction, difficulty dealing with change, anxious or nervous feelings related to social interactions and settings, intellectual difficulties such as difficulty grasping and understanding concepts, sad or dejected moods, and low self esteem. The screening tools that were used for this case was the Autism Spectrum Screening Questionnaire, or the ASSQ, to assess and screen for signs of ASD along with her intellectual disability. It's key to note that this screening questionnaire, it it mainly is tailored towards children or adolescents who have high IQs or mild intellectual disability. In this case, she does have a mild intellectual disability, which she receives special resources for at school. And the DIBAS-R, or Diagnostic Behavioral Assessment for ASD Revised, was actually considered to be used as well because it allows for someone who knows the adolescent best to evaluate and report their presenting symptoms. This can be a parent or a teacher but they're reporting and evaluating their presenting symptoms with social communication and interaction, and it's often combined with another ASD screening tool such as the Autism Checklist, or ACL, to improve diagnostic accuracy. So, following up with that, the we also use the LSAS-CA, which is the Leibowitz Social Anxiety Scale for children and adolescents. I'm sorry if I didn't say that name correct. This is used to assess and measure how social anxiety may be playing a role in the person's life in a variety of different situations. So, interpersonal relationships, normal school interactions, just day to day living. She's at a transitional period in her life. She's 17, she's almost into young adulthood, and she lacks the skills that are necessary for her to function as an adult, such as social skills. She lacks those skills, and it comes from a place of being anxious now, of being placed into social situations where she hasn't had this opportunity to be within groups and or friend crowds, friend groups, whatever you want to call it. Lastly, the Revised Children's Anxiety and Depression Scale and Subscales, or RCADS, and RCADS P, which is the parents, that was the parents' version, is used to measure, assess, and diagnose if the client has social phobia and or social anxiety, or present any other symptoms from the subscales, which includes depression. There's a parent version that allows for the client's mother or father to report, or caregivers to report her symptoms or their symptoms of anxiety and depression across the same 6 subscales. Conceptualization. So the presenting symptoms again were the lack of social and communication skills, low mood, sullen, sulky, often in a daze-like state, isolated, reclusive, introverted, often ignored by peers and parents, or alienated. And these symptoms have led to the decision and proposed diagnosis of autism spectrum disorder with accompanying intellectual impairment, which the DSM-5 code is 299.00 and the F code is F84.0. The severity level is level 1 with some components of level 2. Um, these components do include difficulty coping with change, such as her schedule. If her schedule is interrupted, the client expressed that it would be very upsetting for her and that it would be very hard for her to function and have a good day because she's so used to her days being exactly the same, as well as the experience the experiences of social impairments, even with supports in place and limited initiation of social interactions. So these were the main aspects and parts of level two that I felt the client does present. Though she's mainly level one, she does have some of the symptoms from level two as well. So the modality and treatment types. So the modality is cognitive behavioral therapy to help with change in thinking and behavioral patterns with modifications done to apply to the proposed ASD diagnosis. So the therapies that the interventions that will be mentioned have all been used with people on the spectrum and have been proven to be effective with managing symptoms of ASD along with anxiety, particularly social anxiety, since people on the spectrum do face most do face social impairment and difficulties with social interactions. So the treatments would be CBT therapy. It served as like a building stone for the interventions, which is Massey, Pierce, and the FYFA, and methods used to treat the client by helping identify negative thinking patterns and challenging them while identifying sources of negative feelings. Methods such as cognitive restructuring to help people with social phobia and or anxiety and ASD manage their negative thoughts and improve their social skills. So, Massey, just to go in a little bit about that intervention, it actually pulls from both CBT and ABA therapy, which is a commonly used source of intervention with younger children with ASD symptoms, which looks to indulge in psychotherapy first and foremost, along with psychoeducation to evaluate the family and parents' level of involvement because there's a need for acceptance of the possible diagnosis and understanding along with teaching about the disorder and the options for treatment. So there is already a large gap in the support that Melinda receives from both of her parents. So this will help with kind of gathering the level of support. Know with this diagnosis being in place and knowing that she does have this intellectual impairment along with it, so there needs to be a lot of understanding there and a lot of education to educate the parents on, these are the kind of things to look for, these are some triggers, these are some tools and skills that she was provided with and that we worked on in sessions and should be practiced at home. She should practice these things at home. So psychoeducation can not only teach the client the skills necessary, but also foster awareness levels and ability in their ability to analyze their own feelings, thoughts, and behaviors. This can be done on a weekly basis to provide them with concrete rules and steps of social behavior. So this is where the one-on-one individual therapy, psychotherapy comes in because you're going to be there helping challenging these negative thoughts and replacing them with more positive thoughts while also getting them to analyze their behaviors and how it may be interacting with the relationships and bonds that they're forming with other people. Support systems are very critical to getting new skills to stick and be applied to day-to-day life. Modeling these new skills is also an important piece of the program because it helps increase the changes in adolescent learning abilities as well as their ability to develop these social skills. Now, peers is another one that was mentioned. Peers focuses on teaching the adolescents new skills to create and maintain friendships, manage peer conflict, and peer rejection. Because in this case, Melinda did express during the session, that peer rejection is a thing that she fears because she's often ignored by the people, even in her special resources class, which causes her to have feelings of discomfort, and it can cause her to seclude herself even more. Small groups can also allow for the client to use acquired skills while getting exposure therapy. The FYFA, which is the Facing Your Fears revised adolescent version. It was adapted from Facing Your Fears group therapy for managing anxiety in children with high functioning ASD, and it can help with finding and expanding calming activities, recognizing negative thoughts that occur, and developing coping mechanisms and statements to use along with the exposure to the fear. The exposure will be done little by little to help with reducing the feelings of anxiety that she normally feels when placed into social settings. So these are why these are the interventions that I would like to go over, because all of them kind of go hand in hand and they all pull from CBT as well as ABA therapy. It has been adapted to fit adolescents, which was a very important component because we have a 17-year-old almost young adult. So treatment goals and interventions. The Multimodal Anxiety and Social Skills Intervention Program, or MASI, what focuses on helping the client gain better social skills through CBT training with the uses of cognitive restructuring, as previously stated on the other slide. MASI is said to be based on the principles of CBT by addressing a person's feelings, thoughts, and actions, while helping find links to show how the interactions between those domains can be affecting them, but can also bring about desired changes. So these same things that may be interacting and causing a negative effect and causing these interpersonal relationships not to form or be as effective can also be a source of causing change, because these once these thoughts, feelings, and actions change, once these thoughts and actions change, it naturally would change the feelings towards these things. This works by working collaboratively with the client to find out how their cognitions may be contributing to the feelings of anxiousness and avoidance behaviors, which can fuel faulty cognitions and affect interpersonal relationships with family and peers, which is what Melinda is currently experiencing. From there, the client works on changing negative thinking patterns into more positive ones by one-on-one sessions with the therapist for 12 to 16 sessions, while also working on building adaptive social and communication skills that can be applied in the next stage. So the adaptive skills are just as important as the communication and social skills, because she is once again in this transitional stage in her life. So it's best to address how well she is transitioning, being that she is severely lacking in a lot of developmental areas. So the next stage will include another intervention, which is the peers program that I mentioned before, which allows for clients and their parents to attend group meetings. For Melinda, it would be best to use maybe a small group setting, because she does get a little bit anxious when she knows that she's going to have to interact with other people. It's because she goes to school every day and she's not really anxious about that all the time, only when she knows she's going to have to interact with other people. This allows the utilization of newly acquired social skills and develop new understandings of social cues in a more comfortable environment, which can hopefully eliminate the feelings of embarrassment, being that these are all people who have like symptoms. The last intervention will be Facing Your Fears adolescent version, which uses some of the same traditional methods and principles from CBT as peers and MASI models do, and usually lasts for the same time slot as those two, which is around 14 weeks or 12 to 16 sessions. So the strengths and challenges of these interventions and this model and modality. So it focuses on presenting symptoms of anxiety and emphasizes family involvement, which would be a very big thing for Melinda, because she has saddened feelings because she's not really supported by those around her. Her mom normally just talks about the things that she does wrong, and never asks like maybe what's going on, like what are these difficulties coming from. So she needs that familiar involvement and for them to be a support system for her. It also provides skills for better social development, provides the client with opportunities to practice these skills inside and outside of the individual and small group sessions, and improves familiar relationship and provides the client with psychoeducation on diagnosis and how to manage symptoms in and outside of the home. Challenges that come along with it, though, are lack of research and attention to ASD symptoms in adolescent girls compared to boys, because girls are severely under evaluated and the symptoms may present differently, and girls often conform more, which is why Melinda also doesn't show at the more typical signs and symptoms of ASD, besides the mannerisms that she cannot help, like the um, the repetitive schedule, the repetitive behaviors, doing the same things. There's also the possibility of lack of compliance from both the client or their parents who already lack the desire to be involved. There also could be a lack of mutual understanding and communication, and it can also be overwhelming or triggering at the introduction of the small group, which would be the exposure therapy, being that these types of things do freak her out and make her very weary. So with anything will come strengths and challenges. I feel that the good outweighs the bad, and I feel like these are just once again speculations that could not be factual. She could just be totally successful, or it could be a total bust, and you have to go back and start over and find new methods, and that's fine because it's all about finding the things that work best with the client. So that was my presentation. Thank you so much for listening to it. These are just a few quotes and pictures that I wanted to throw here. Autism is not a boys club. This is kind of pertaining to the last thing that I spoke about. Autistic is not a bad word because social media can sometimes attach negative connotations to these neurodevelopmental disorders. And autism is a part of my child, is not everything that he is. My child is so much more than a diagnosis. This was done by a mother of a child with autism, and I felt that it was very fitting and that it's the type of support that Melinda would need. Once again, thank you so much.